Good afternoon. I went through a lot of literature to understand what exactly is meant by mid-flexion instability. And at the end of the day, I came to conclusion that we still really don't know what exactly is the problem about. It's not a very simple thing because it's a problem where some people give you a single radius knee as an option of treatment, and other group vehemently also say that multi-radius is the only answer. So I think we still don't know what about it. But if you get a knee which is unstable and you need to do something about it, how do you approach that? Now, how common is the unstable knee? Fairing has mentioned 27% revisions in TKA are done because of instability in the knee joint. Coutinho in OCNA mentioned that it is the second most important cause for revision of knee after infection. So it is quite important complication of the TKR surgery. As we have already discussed this, that types of instability could be acute or chronic. Acute is when the patient has fallen down or immediately post-surgery when some ligament has gone wrong. And in chronic, it is an ongoing process where it is not a very severely unstable joint but become painful later on. Depending on position, it is categorized as flexion instability or extension instability or a hyperextension instability. In extension, there are two things. Either it is a component malalignment or it is a soft tissue problem. Like in this patient, you can see that patient has got a significantly valgus tibia and a valgus femur, which has resulted into excessive lateral laxity, and obviously this knee is going to be unstable when a patient walks. On the other hand, this patient has severely varus position of the tibia and balancing varus, so joint line is oblique now, and when the patient walks again, he is not going to feel normal on his knee. Another patient having a significantly reverse slope and excessive change in a slope, either forward or backward, can cause the knee to feel unstable when a patient is especially going upstairs or downstairs. Position classification of flexion basically include much more complex things than just the alignment of the implant or a soft tissue balance, undersizing of the component, wrong rotation of the femur, too deep posterior slope, too much distal femoral cut causing high joint line. All these things will change the biomechanics of the knee in a flex position. Among them, MCL is very important part, and a loss of MCL either iatrogenic by surgeon or because of the disease process, like in a case of type 2 valgus knee, can lead to knee which is unstable at the end of the surgery if surgeon is not very careful. Is PCL important factor in TKA stability? Well, there are contradictory opinion. People who want to preserve it, they feel that it is important, but again in a very arthritic knee, that PCL has to be properly released. If it is not released, if it is too loose, it becomes unstable. If it is too tight, it leads to a fixed and stiff knee. Role of flexion extension again has been discussed. I won't elaborate on that. So if you get an unstable knee, what are the symptoms? How you diagnose that? Pain, instability, recurrent swelling in the knee joint, and difficulty in stair climbing. These are the common symptoms in the patient when they complain of instability. But if you realize these are the same symptoms which are seen in other conditions. If the patient has early implant loosening, if there is low-grade infection, if there is neurological problem, again the knee can become painful chronically. It may develop chronic swelling again and again, and that may be labeled as an unstable knee. So you must, when you try to treat this unstable knee, be careful about ruling out these options. So when you want to have a patient to be labeled as an unstable knee, you must rule out neurological condition, low-grade infection. We must take detailed history and clinical examination, and which is very important in diagnosis of unstable knee. Knee must be examined in 90-degree flexion with foot resting on a footstool and drawn forward like a drawer test. You can take stress radiography to see varus valgus alignment. You can take a full scanogram, and you can take a true AP and lateral views to know exactly how much the posterior offset, anterior offset is there. And we may take a CT scan to see the rotational alignment of the knee, because that's the only way you can find out if the femur is mal-rotated. So if you diagnose, then what are the treatment options? The surgeon or the surgeon must have high index of suspicion about this. You must analyze the cause of instability, and this is very, very important. If you don't analyze why the knee is unstable and pinpoint the cause, treatment may not be successful. So when you do revision TKR, because unstable knee has no conservative options, you have to revise the knee. You must make sure that we recreate the neutral alignment and a proper soft tissue balance. We must make sure that there is equal flexion extension gap. We must make sure that the joint line is restored by using either a distal augment to the distal femur. You must have a proper rotation, and that is most difficult part of the knee revision surgery. You must maintain the posterior offset by selecting proper femur size, and you must have adequate constraint in the revision implant. And this constraint depends on how much is the severity of instability. So in conclusion, you must identify those patients who are at a higher risk of future instability, and then select proper implant, meticulous care while doing soft tissue balance and bone cuts, and then have a proper post-op rehab. Remember that instability in TKA is better avoided than treated, because treatment and diagnosis is not very easy. Treatment in most of the cases is revision with a higher level of constraint depending on level of instability, and it may end up having a hinge knee, the last option in these patients. Thank you very much.